Hello, am I audible?
Yes, sir. Scanning the page starts simple. Your live stream started, please.
Hello. Can I start? Can I start? Can I start? Is it live streaming right now? Okay then, right. Good evening everyone. Today we are going to discuss about some important aspects which are frequently asked in our FMGE. So basically we have a 2-hour session today and one more 2-hour session on Monday. Today we are going to see some important questions. So let us directly go to the questions right now. Okay. I will be waiting for your answers. Let us go to the first question. A term baby delivered by LSCS has not cried after birth and the tone is floppy. After initial resuscitation with positioning, suctioning and tactile stimulation, the child is still apneic and the heart rate is less than 100 per minute. Positive pressure ventilation with the bag and mask started, but after 30 seconds of bag and mask ventilation, the heart rate is 80 and the child is still apneic. What is the next step? 1. Call for assistant and start chest compressions. Consider endotracheal intubation. Give adrenaline through umbilical vein. Continue ventilation and take ventilation correction steps. Over to you, my dear friends. So what is the next thing that you are going to do in this case? This is a term baby delivered by LSCS, has not cried immediately after birth and the tone is floppy. After tactile stimulation, till the child is apneic, heart rate is less than 100, positive pressure ventilation with the bag and mask started. After 30 seconds of bag and mask ventilation, the heart rate is still 80 and the child is apneic. What is the next best step? Can you tell me your answers? So the most important aspect with respect to our pediatrics is newborn. In newborn, we need to concentrate on neonatal resuscitation. At least one question will be asked from this neonatal resuscitation and we need to solve this scenario. What is the scenario and what does this deals with it? Right. Simple. Is this child needs resuscitation? The answer is yes, because the child did not cry after birth. The child did not cry after birth and the tone is floppy. As you all know, absence of cry after birth and the tone is floppy, we need to start resuscitation. And the resuscitation initially includes your basic steps of resuscitation such as positioning, suctioning, tactile stimulation. But after that also the heart rate is still less than 100 per minute. So you are starting your bag and mask ventilation. But despite bag and mask ventilation, the heart rate is still 80 and the child is still apneic. What is the next step? Choice number 1, call for assistant and start compressions. The indication for chest compression is the heart rate is less than 60 per minute. Here the heart rate is 80. So there is no need for chest compression. 2. Consider endotracheal intubation. And we all know that when the heart rate is less than 60 per minute, you will give ventilation as well as you give cardiac massage. Even after successful cardiopulmonary resuscitation, if the child is not still responding, you might need to consider endotracheal intubation. At times you need to consider endotracheal intubation even before your chest compression. But here the heart rate is descending even after 30 seconds of bag and mask. Give adrenaline through umbilical vein. Again, what is the indication for indication for adrenaline? The indication for adrenaline is despite successful CPR for more than 1 minute with cardiac massage and bag and mask ventilation. If the heart rate is continued to be low, less than 60 per minute, after 1 minute of CPR, you will consider starting adrenaline. But here the first step itself is a false. You are not doing your ventilation properly. What do you mean by that? You are not doing your bag and mask properly. If you do your bag and mask properly, automatically your heart rate will increase. So first and foremost, before considering endotracheal intubation, before considering cardiac massage, you need to consider one important thing, that is whether are you doing a correct bag and mask ventilation. If your bag and mask ventilation is proper, almost every child will show some form of improvement in increase in heart rate. So what do you mean by that ventilation correction steps? So the answer here is continue ventilation and ventilation correction steps. So what do you mean by that ventilation correction steps? Before that, let us see some aspects of neonatal resuscitation. Whenever you see any child which is a term baby and the child is not breathing and the child tone is poor, that is what we see in this case. A term child which is not crying immediately after birth, leading to hypotonia. And because of this, what you need to do? You need to go for initial steps of resuscitation. What do you mean by initial steps of resuscitation? You need to clear the airway with suctioning. You need to dry the baby, stimulate the baby, keep the baby under radiant warmer. And you need to take a minimum of 30 seconds for all those things. After initial steps of resuscitation, you need to assess the heart rate. If the heart rate is less than 100 per minute and the child is gasping or apneic, you need to start your positive pressure ventilation at the end of 1 minute. Remember, positive pressure ventilation should be started at the end of 1 minute after birth if the heart rate is less than 100 per minute, despite your efforts with respect to initial steps of resuscitation and stimulation failed to increase the heart rate. After 1 minute, you are starting your positive pressure ventilation and you need to assess whether the heart rate is increasing or decreasing. If the heart rate is still less than 100 per minute, you need to consider taking ventilation correction steps. So what do you mean by that ventilation correction steps? Simple. You are doing bag and mask, but your bag and mask position, everything is not proper. So how to correct this ventilation steps? The famous clue is called Mr. Sopa. What is that called as? Mr. Sopa. MRSOPA. So what do you mean by that? You need to apply the mask and it should snugly fitting, covering your nose as well as your mouth. Point number 1. So your mask should snugly fit so that it should cover your mouth as well as your nose. Second, reposition the neck. Second point is reposition of neck. So what do you mean by reposition of neck? You need to put the neck under sniffing position. What do you mean by that sniffing position? The sniffing position is meant by you are keeping a roll of towel under the shoulder blade. So sniffing position. So what do you mean by sniffing position? You need to keep a roll of towel under the shoulder blade so that your nose, your nasopharynx and your trachea will be in a straight line. Second. Third one is suction. You all know that whenever the baby doesn't cry immediately after birth, you could find plenty of secretions in the mouth as well as in the nose. So you need to suck, you need to properly suck the secretion that is present in the nose and mouth. So S stands for suction of mouth followed by nose. And also remember what is called O. O is called open the mouth. O is called open the mouth. O is called open the mouth. So you need to open the mouth. So when you open the mouth widely so that you can do your suction, you can do your bag and mask properly so that your bag and mask ventilation air that goes properly inside the trachea. Okay, then P. What do you mean by P? P stands for what? P stands for adequate pressure. When you don't give proper pressure, what will happen? Your air that is the pressure which is produced by the bag and mask is not proper, so that air will not enter your trachea properly. And finally, what is called A stands for alternative airway. If despite all these efforts, if your oxygen, your heart rate doesn't increase, you need to either go for a laryngeal mask airway or you need to intubate the child. If you are not sure with respect to your intubation, you can start laryngeal mask airway, and if you are well versed but doing a endotracheal intubation, you can do a endotracheal intubation itself. So when the child, what is the first step? The first step that you need to know, that you need to do immediately after when the baby doesn't cry is suctioning, positioning the baby under sniffing position, and then you need to dry the baby, suctioning of the mouth, suctioning of the nose, keep the baby under the radiant warmer. If the baby doesn't cry, stimulate the baby by gentle rubbing of palms and soles as well as gentle rubbing of back, and it's a simple tickling of palms and soles. If the baby still doesn't cry even after 1 minute of success, 1 minute of all these measures, you need to go for a bag and mask ventilation. After 30 seconds of bag and mask ventilation, if the heart rate doesn't increase beyond 100, you need to do ventilation correction steps. What are all the ventilation correction steps? It is called Mr. SOPA. M for properly positioning the mask, reposition of the neck, suctioning of the mouth followed by suctioning of the mouth, open the mouth and put proper pressure over the bag and mask, and finally you need to go for a alternative airway. Alternative airway either in the form of laryngeal mask airway or in the form of endotracheal intubation. Then what you need to do? After ventilation correction steps, if the heart rate is still less than 60 per minute, what you need to do? You need to go for, yes, you have already considered intubation in the previous step. Then you need to consider, if the heart rate is less than 60 per minute, you need to consider chest compression along with positive pressure ventilation. After 1 minute of chest compression along with the positive pressure ventilation, if the heart rate is still less than 60 per minute, you need to go for IV adrenaline. The available adrenaline dose is 1 in 1000, and you need to mix with 1 ml of adrenaline should be mixed with 9 ml of normal saline, so that you will get 1 in 10,000 adrenaline. In that 1 in 10,000 adrenaline, you can choose 1 ml per kg to 0.03 ml per kg either through a peripheral vein or an umbilical vein, or else you can try an endotracheal route. If nothing can be achieved, then it can be tried through intraosseous route. So this is with respect to the neonatal resuscitation. What are all the new things that had come to the neonatal resuscitation? First point, umbilical cord clamping. Previously, before 2014 guidelines, we don't use that delayed cord clamping, but right now a delayed cord clamping is allowed. What do you mean by delayed cord clamping? You need to clamp the cord, cut the cord 30 to 60 seconds after birth, because so that the blood that is present in the placenta will reach the baby and prevent the neonatal and infantile anemia. That is the main issue. Second point is, previously people have been using RL for shock correction before you start your adrenaline infusion or adrenaline injection. But right now you are not supposed to use RL. Either 10 ml per kg of normal saline or 10 ml per kg of O negative blood is used. RL is not used. And again, previously bag and mask ventilation is contraindicated in case of meconium aspiration, but right now bag and mask ventilation is not a contraindication for meconium aspirated baby. Bag and mask ventilation can be done even in meconium aspiration baby. Right now the contraindication for bag and mask ventilation is diaphragmatic hernia and it is not meconium aspiration. So this is with respect to the neonatal ventilation. Second question, again a question from newborn. So what is this question? What would be the preferred initial method of feeding in a newborn of 33 weeks of gestational age? Preferred initial method of feeding in a newborn of 33 weeks of gestational age. Are you using a total parenteral nutrition such as an IV fluid, or a nasogastric tube feeding, or a direct breastfeeding, or a Paladay feeding? What are all the things that you can do in a 33-weeker baby? So what is the answer? Can anyone tell me what is the answer for a 33-weeker? The answer is very, very simple. So initially, you don't have good maturity of the intestinal gut. You don't have good maturity of the intestinal gut. So less than 28 weeks, intestinal gut maturity will not be achieved, as a result of which less than 28 weeks the preferred method is IV fluids. Second point, but after 28 weeks, from 28 to 32 weeks, intestinal maturity will be achieved, but there will be problem with the sucking and swallowing coordination, as a result of which you need to bypass that sucking and swallowing, so that a nasogastric tube or a orogastric tube will be introduced into the stomach, and through that you will give your breast milk. And this nasogastric feeding or orogastric feeding is followed between 28 to 32 weeks. Second, when do you follow direct breastfeeding? Direct breastfeeding. Okay, so less than 28 weeks, 28 to 32 weeks, and then between 32 to 34 weeks, swallowing will be achieved, but sucking will not be achieved, so that a Paladay feeding can be given, so that you can bypass your sucking, but you can give work to the swallowing. So from 32 to 34 weeks you can give Paladay for Gokarnam feeding. And finally, direct breastfeeding can be achieved after 34 weeks of gestational age. Because by that time your sucking and swallowing coordination occurs absolutely. So what is the answer for this question? For a 33-weeker, you need to go for Paladay feeding. Okay, less than 28 weeks, directly go for intravenous feeding. 28 to 32 weeks, orogastric feeding. From 32 to 34 weeks, spoon, cup or Paladay or Gokarnam feeding. And finally, beyond 34 weeks, you need to give your breastfeeding. So this is with respect to various types of method of feeding in a preterm baby. An often asked question. Then comes your respiratory distress. First we have seen neonatal resuscitation. Second, we have seen what kind of feeding that can be achieved in a case of preterm baby. And the third question, let us go to the third question. This is a 3-hour-old preterm male baby of 30 weeks gestational age admitted in NICU with a respiratory rate of 70 per minute, moderate retractions, mild cyanosis in room air which disappeared with 30% oxygen, and the child is not having any grant, the child is not having problems with respect to the air entry. The child was started on a CPAP of 5 cm of water. After 8 hours, child developed grunting that can be audible with stethoscope, and the respiratory rate become 84 per minute. CPAP was increased to 7 cm and FiO2 has been increased to 60. But the child respiratory distress did not settle down. X-ray chest showed reticulonodular pattern with the air bronchogram. What is the next step in this management? Before approaching this complex case scenario, let us make something simple. How to approach a case of neonatal respiratory distress? So we are going to see neonatal respiratory distress. So what do you mean by neonatal respiratory distress? What are all the things that we see in neonatal respiratory distress? What are all the scores that you see? One score is Downey score. Downey score is mainly meant for term babies as well as for preterm babies, and one more score is called as Silverman-Russell score, and this is peculiar idea. This is mainly meant for your preterm babies. So what are all the various parameters that is followed in Downey score? So one is rate, second one is retraction, third one is air entry, fourth one is oxygen requirement, and fifth one is grunting. These are all the things that we follow in a case of Downey score. So what do you mean by Downey score? In Downey score, you look for respiratory rate, you look for retractions, you look for cyanosis, you look for air entry, and you look for grunting. There are 5 parameters that we see in case of Downey score, and it will be given a score of 0, 1 and 2. Respiratory rate of less than 60 per minute, no retractions, no cyanosis, equal air entry, and no grunting were given a score of 0. Whereas respiratory rate of 60 to 80 per minute, mild retractions, cyanosis requiring less than 40% oxygen, air entry minimally reduced, and grunting heard with stethoscope are given a score of 1. Whereas your respiratory rate of more than 80 per minute, retractions moderate to severe, cyanosis requiring more than 40% oxygen, air entry markedly reduced, grunting heard even without stethoscope is given a score of 2. Let us see what this is with respect to Downey score, and how to approach a case of neonatal respiratory distress. That is very easy. First of all, you need to see whether it is a term or whether it is a preterm baby. So to start with, whether it is a term or preterm baby, whether it is a term or preterm baby. You all know that preterm babies are prone to get respiratory distress because of 2 reasons. One is hyaline membrane disease, second one is hypothermia. Even a simple hypothermia can lead to severe respiratory distress because hypothermia stops or reduces almost all metabolic functions of the body. Right. So first one is whether it is a term, or whether it is a preterm baby. And you need to classify whether the respiratory distress onset is less than 6 hours or more than 6 hours. Again in preterm also, whether it is more than 6 hours or less than 6 hours. Remember, the causes for respiratory distress with respect to term and preterm is same when it comes to more than 6 hours. whether it will be associated with the increased liver span. It means you are dealing with a case of congenital heart disease. You are dealing with a case of congenital heart disease. Whereas if it is associated with a shock, you are dealing with a case of sepsis. Both term and preterm, it is one and the same. If liver is increased, you are dealing with a case of congenital heart disease. If the child is presenting with a shock, you are dealing with a case of sepsis. This is common with respect to both term and preterm. Whereas in case of preterm, less than 6 hours, most common cause, as you all know, is one is hyaline membrane disease, second one is hypothermia. Whereas in case of term babies, so preterm babies less than 6 hours, hyaline membrane disease or hypothermia. Both in preterm and term babies, the causes for more than 6 hours is only two things. If it is associated with hepatomegaly, think in terms of heart disease, congenital heart disease. If it is associated with a shock, more often it is a manifestation of neonatal sepsis. And less than 6 hours in case of term baby, either it can be a sick baby or well baby. Well baby means two most common causes. Yes, as all you know, one is transient tachypnea of newborn, another is polycythemia. Whereas in case of sick baby, either it can be due to meconium aspiration syndrome, or it can be due to, can anyone tell me, or it can be due to, one is meconium aspiration syndrome, another is HIE stage 2, So this is the general approach to neonatal respiratory distress. By simply analyzing the time of onset of respiratory distress and whether it is less than 6 hours or more than 6 hours, whether it is a term or preterm, if it is a term, whether it is a well baby or sick baby, you can easily identify the cause of the neonatal respiratory distress. Let us come to our question. So what is our question? So what are all the questions that can be asked in this particular question itself? We have discussed extensively about a Downey score. We have discussed about approach to neonatal respiratory distress. But with respect to this question, what is the thing that we need to do? So how you are going to approach a case of hyaline membrane disease? Again, the answer is very simple. How you are going to approach a case of hyaline membrane disease? Whenever you see a case of hyaline membrane disease usually occurs, as you all know, in a preterm. It doesn't mean that whenever you see any case of preterm baby with the respiratory distress, always you need to give surfactant. It is not so. So how to approach them? First of all, you need to look for Downey score. Downey score can be 0 to 4. Downey score can be 0 to 4, 4 to 7 or 7 to 10. I repeat, Downey score can be 0 to 4, 4 to 7 or 7 to 10. Based on that, it can be divided into mild, moderate and severe respiratory distress. So Downey score 0 to 4, 4 to 7 and then 7 to 10. It is respectively classified as mild, moderate and severe respiratory distress. Along with that, two more things you need to see. What you see in an X-ray and again you will see whether the child is apneic or not. Mild, moderate, severe Downey score, as well as in X-ray chest whether you will see a ground glassing or you will see a complete whiteout lung. And if the child is having complete whiteout lung, the child will be frequently having your apnea. So based on that, how you are going to treat? When the child is having moderate respiratory distress along with the mild ground glassing lung fields, along with the no apnea, or else I can say a normal X-ray I can say a normal X-ray with a moderate respiratory distress without apnea. The treatment of choice is very simple. You use CPAP. The treatment of choice is you use CPAP. What do you mean by CPAP? CPAP means continuous positive airway pressure. CPAP means continuous positive airway pressure. So you need to give CPAP, continue positive airway pressure. Then despite CPAP, if the respiratory distress is increasing, okay, along with some ground glassing, and without any apnea, you need to go for insure. What do you mean by insure? So respiratory becomes severe and the X-ray shows GGO and there is no apnea, means you need to go for insure. What do you mean by insure? Insure means intubate, surfactant administration and extubate. Insure means what? Intubate, surfactant administration and extubate. That is called insure technique. Intubate, surfactant administration and extubate. But despite that, if the child is having complete whiteout lung along with the frequent apneic spells, then you need to mechanically ventilate the baby and you need to give surfactant. So, and if the child is having apnea, you need to give, So, no apnea, but respiratory distress is increased beyond CPAP. You need to give what? Insure. Insure means what? Intubate, surfactant administration and extubate. Finally, when the child is having apnea or complete whiteout lung, you need to go for what? Mechanical ventilation along with surfactant administration. So what is the one that we are going to follow in this case? Look at this. This is a preterm baby. And the baby developed tachypnea of 70 per minute, moderate retraction and mild cyanosis. The child was started on CPAP. But despite the child was started on CPAP, the respiratory rate is increasing, the tachypnea is increasing, the child is having ground glassing with air bronchogram. So what is the next step? The next step is exactly, very good. The next step is intubate, surfactant and extubate. This is called extubate. Then you connect the baby to continuous positive airway pressure. This is called insure technique. So when you will consider mechanical ventilation, the mechanical ventilation along with surfactant should be considered when the child is apneic and going for frequent apneic spells along with the full whiteout lung. So the answer for this question is 3C. Let's go to the fourth question. What is this fourth question? A 3-hour-old child born of LSCS, indication postdated pregnancy. We all know that postdated pregnancy is prone for meconium aspiration. And the child is having, as it goes, thick meconium stained liquor, resuscitated with a tracheal suctioning, developed respiratory distress with a Downey score of 5. The child was started on CPAP. Chest X-ray did not reveal any hyperinflation. After 24 hours, the distress worsened and the child could not maintain saturation and became cyanosed even with 70% oxygen. On auscultation, the air entry was diminished on the left side. Choose the appropriate and immediate management. Remember, postterm are more prone for fetal distress. How it is prone for fetal distress? Because it used to pass meconium inside even before birth, as a result of which the child usually aspirate the meconium content, it will go and block the major airways, that is your trachea. Even if not, it goes deep inside the airway, leading to meconium aspiration syndrome. As a result of which, any postterm baby and it is born with a history of thick meconium plug and respiratory, and if it develops respiratory distress, you need to consider meconium aspiration syndrome as your first diagnosis. Yes, this case has went for meconium aspiration syndrome and the child is started on CPAP. But what happens here, despite starting CPAP, and the child condition suddenly worsens. Remember, any child who has developed respiratory distress following meconium aspiration is prone for two complications. One complication is pneumothorax, because various sites of block will be present across the entire airways because of the meconium plugs, and the child invariably will be under mechanical ventilation because of the blocks produced by the thick meconium. Because of the invasive ventilation such as mechanical invasive ventilation, what will happen, the child is prone for pneumothorax. And how to identify this pneumothorax? The child whose Downey score of, let it be 4 or 5 on mechanical ventilation, suddenly becomes cynosed and requiring much oxygen and much pressure, you need to consider DOPE. Your child on ventilator, if suddenly worsens, you need to consider DOPE. What is DOPE? DOPE means, what do you mean by DOPE? Displacement of endotracheal tube. First one is displacement of endotracheal tube. Second point, O for obstruction. Endotracheal tube is prone for obstruction. P for pneumothorax, air leak syndrome, and E for equipment malfunction. So this child, a case of meconium aspiration syndrome, has gone for sudden worsening and there is a reduced air entry on one side. Reduced air entry on one side, unless otherwise proved, it directly goes without saying that there is an air leak on that side. What is the immediate management? The immediate management is, yes, as you all think, the immediate management in this case is needle drainage. Where you will put your needle drainage? The needle drainage will be done under the left infraclavicular area, so that the air usually gets collected in the upper part, will be drained. Okay. After needle drainage, you can consider intercostal drainage through a intercostal tube. The question here is air entry diminished on the left side, which indicates that there is a air leak or pneumothorax on the left side. Second point, what is the immediate treatment? The immediate treatment is put a needle under the infraclavicular area so that air will come out, and then it can be followed by ICD placement. That's it. And one more point, if the child, one more complication of meconium aspiration syndrome is, if the child doesn't show any features of all these things, but despite not showing improvement in the form of increase in oxygenation even after 5 to 7 days, what you need to consider? You need to consider persistent pulmonary hypertension. What do you mean by persistent pulmonary hypertension? It is simple. Almost in all parts of the body, vasodilation will occur with response to hypoxia. The only area where hypoxia leads to vasoconstriction is in the lung. So what happens, because of the thick meconium plugs at various levels of airways, it leads to obstruction and hypoxia. This obstruction in turn leads to pulmonary vasoconstriction, leading to persistent pulmonary hypertension. So what is the carry home message from this fourth case scenario? The carry home message from this fourth case scenario is very, very simple. A child who suddenly worsens, a child of meconium aspiration when suddenly worsens, who is on a ventilator and suddenly worsens, with a reduced air entry on one side, think in terms of a pneumothorax and do a needle drainage. If by about second cause, by about 5th or 6th day, the lung has become clear, there is no pneumothorax, there is no equipment failure, there is no obstruction, there is no displacement, but the child is still cyanotic, means then you need to consider in terms of persistent pulmonary hypertension. What is the treatment for persistent pulmonary hypertension? The treatment for persistent pulmonary hypertension is, first one is oxygen, because lack of oxygen hypoxia leads to vasoconstriction, so you give oxygen. Second point, vasodilators like inhaled nitric oxide can be used, sildenafil can be used. Your endothelial receptor antagonist like bosentan can be used in case of persistent pulmonary hypertension. But as far as this case is concerned, the clue here is air entry was diminished on one side, so you need to consider pneumothorax. So what is the next management? Needle drainage followed by intercostal drainage. Needle drainage followed by intercostal drainage system. Drainage. Fourth. Yes. What is this? Another cause for neonatal respiratory distress. A newborn with respiratory distress and you had shown an X-ray. What does this X-ray shows? And tell me the differential diagnosis. What does this X-ray shows and tell me your differential diagnosis. Tell me your differential diagnosis. Yes, absolutely. You could see numerous cystic lucency or spaces in the right hemidiaphragm. Point number 1. Second point, you could not see a proper diaphragm border. Second. Third one is because of presence of intestinal lumens in the right hemithorax, there is mediastinal shift to the left. So all these things goes in favor of a congenital diaphragmatic hernia. You could see numerous lucency space. Here you could see a diaphragm border. Here you could not see a diaphragm border. Along with that, there is a mediastinal shift to the left. That means a mass is occupying the right hemithorax. The mass is nothing but your intestinal lumen. Other surgical causes for neonatal respiratory distress are 1. What are all the other causes for neonatal respiratory surgical causes? We have seen causes for medical cause for respiratory distress here. What are all the surgical causes? One is diaphragmatic hernia. How you will catch diaphragmatic hernia? A child with scaphoid abdomen. Why scaphoid abdomen? Because the intestinal contents will go inside the hemithorax. As a result of which you will get scaphoid abdomen. Second point, if you have a frothing when the child is feeding, it means you are thinking in terms of a tracheoesophageal fistula. So one is congenital diaphragmatic hernia, second is tracheoesophageal fistula, third one is congenital lobar emphysema. What is this congenital lobar emphysema? You could see a non-functioning lung. I repeat, you could see a non-functioning lung in the left upper lobe. Non-functioning lung in the left upper lobe. So what you will see, you could see an emphysematous lung along with a mediastinal shift. So what will happen? The mediastinum will be discussed in detail in our videos of PW. The mediastinal will be shifted to the right and air entry will be reduced. These are all the surgical causes for congenital diaphragmatic hernia. I repeat, apart from medical causes, the surgical causes are congenital diaphragmatic hernia, tracheoesophageal fistula and congenital lobar emphysema. Often asked question is congenital lobar emphysema. What you will see in a case of tracheoesophageal fistula, you could see an NG tube coiling at the level of the neck. That's why any case of neonatal respiratory distress, whenever you want to take a X-ray chest, you need to put an NG tube, then you need to go for an X-ray, so that if at all there is a coiling, that could be visible in the X-ray. This is our fifth question. Next, what is the first step in the evaluation of a short stature? I repeat, what is the first step in the evaluation of a short stature? First is bone age. Second one is look for sexual maturity rating scale. Third one is mid-parental height. Fourth one is you need to look for weight for height. So what do you mean by evaluation of a short stature? Yes, what is the answer for that? Yes, many of you know that the answer is mid-parental height, because the most common causes for short stature is familial short stature. What do you mean by familial short stature? When the father height is low, mother height is low, invariably the child who is born to them will also be low. That's why it is called familial short stature. That is the most common cause that should be ruled out first. What are all the steps in evaluating a short stature? Let us see one by one. One by one. Right. Point number 1. Rule out systemic illness. The child must be suffering from evaluation of short stature. The child must be suffering from so many things. If a child is having VSD, ASD, TOF, any chronic lung disease, cystic fibrosis, Wilson's disease, nephrotic syndrome, so many things can happen. If the child is having systemic illness, whatever you eat will be utilized for catabolism, as a result of which the height will not be achieved. The first common cause for short stature is rule out systemic illness, or a chronic infection such as TB can also be a short stature. One. Second one is other physiological causes. Other physiological causes. So what are all the physiological causes? One is familial short stature. Second one is constitutional growth delay. What do you mean by familial short stature? If the father is short, mother is short, the child will be automatically short. This is called familial short stature. How it can be achieved? It can be achieved by using simple thing called mid-parental height. Mid-parental height. How do you calculate this mid-parental height? Whenever a child is brought for evaluation of short stature, you need to look at the father height divided by 2 plus mother height divided by 2. And if it is a boy, plus 6.5, and it is a girl, minus 6.5. For example, let me say the father height is 170 centimeter divided by 2 and mother height is 160 centimeter divided by 2. So how much it comes around? 85 plus 80, which roughly comes around what? 165 centimeter. 165 centimeter, and you need to add plus 6.5 if it is a boy, that is 166, or minus 6.5 in case of boys, or minus 6.5 in case of girls. So it can be 154. So along with that, it can be plus or minus 7 centimeter or plus or minus 8 centimeter. So invariably a child whose height will fall under this category. With this category. So when father is short, mother is short, the child will be invariably short. This is called familial short stature. Second cause for is constitutional growth delay. What do you mean by constitutional growth delay? As you all know that the final increment in growth velocity occurs during puberty. If puberty is delayed, the final height that will be achieved during puberty will also be delayed. That is postponement of puberty, leading to physiological postponement of puberty that usually occurs in some boys, usually leads to postponement of increase in height. For example, in familial short stature, a child is short from birth up to puberty and beyond that, whereas in constitutional growth delay, a child will be short before puberty and puberty will be delayed. So instead of occurring at 14 years, puberty, let me say, occurs at 18 or 19 years. So the height velocity, the height increment that is supposed to occur at puberty is postponed from 14 years to 18 years, as a result of which the final height achieved will be normal. I repeat, final height achieved will be normal. So constitutional growth delay is due to delayed puberty. Constitutional growth delay is leads to delayed puberty, and it usually runs in family. You can ask that kind of history in father. So how do you ask that history in father? Very, very simple. When does the father had started his shaving first? When does the father removed his mush? All those things can be asked. So this is called as constitutional growth delay. Here the final height will be normal. The final height will be normal. So first one is systemic illness, second one is physiological conditions like familial short stature and constitutional growth delay. Third cause for short stature is, I used to teach my students as HTC. H for hypothyroidism, T stands for Turner syndrome, and C stands for celiac disease. Any child with a physical and mental retardation, unless otherwise proved, it is a case of hypothyroidism. A girl with short stature should be evaluated for Turner syndrome unless otherwise proved. Third syndrome, celiac disease. Celiac disease means gluten insensitivity. Gluten sensitivity. What does it mean? The gluten that is present in the wheat and so many things will cause a damage to the small intestine, as a result of which malabsorption occurs. This malabsorption leads to short stature. The triad of short stature plus diarrhea or malabsorption plus pallor. Pallor means what? Irida. What do you mean by irida? Iron resistant iron deficiency anemia is called as irida. This triad of short stature, diarrhea and pallor is called as celiac disease. So these three common causes has to be ruled out for short stature. And finally, the last common cause is growth hormone deficiency. Common cause is growth hormone deficiency. So what are all the characteristic features of growth hormone deficiency? The characteristic features of growth hormone deficiency are neonatal hypoglycemia. One is neonatal hypoglycemia, because your growth hormone is a catabolic hormone. Birth is a process of severe stress. During that time, sugar has to be increased by your growth hormone, your ACTH as well as steroids. If any one of these absent, the child will be prone for neonatal hypoglycemia. Second one, there will be an associated midline cleft lip or cleft palate. Third one, there will be infantile genitalia. Why there is infantile genitalia? Apart from growth hormone deficiency, there will be deficiency of gonadotropic hormones like LH and FSH. LH and FSH. Right, this is about growth hormone deficiency. Finally, in any case of short stature, the two things that we need to know is, one is bone age, chronological age. Bone age, chronological age. Remember, if your bone age is equal to chronological age, you are dealing with a case of familial short stature. You are dealing with a case of familial short stature. If your bone age is less compared to chronological age, if your bone age is less compared to your chronological age, two things can occur. Either it can be a case of constitutional growth delay if the bone age chronological age difference is less than 2 years. If the bone age chronological age difference is more than 2 years, you need to consider either hypothyroidism or you need to consider growth hormone deficiency. So bone age chronological age difference less than 2 years and more than 2 years. Less than 2 years, you need to think in terms of constitutional growth delay, and more than 2 years, you need to think in terms of either growth hormone deficiency or hypothyroidism. And finally, when your bone age is more than chronological age, it is called as precocious puberty. It is called as precocious puberty. So this is how you need to apply the rule of bone age and chronological age to find out the etiology for short stature. And one more thing, upper segment, lower segment. That will be discussed in detail in our videos of PW. Upper segment and lower segment. Remember, when the upper segment to lower segment ratio is high, what does it mean? It means it is short limb dwarfism. It means it is short limb dwarfism. Short limb dwarfism. So what are all the causes? Hypothyroidism. What are all the causes? One is hypothyroidism. Second one is achondroplasia. Third one is rickets. Fourth one is Turner's. Achondroplasia, hypothyroidism. So one is hypothyroidism. Second one is achondroplasia. Third one is rickets. Fourth one is Turner. These are all the causes for increased upper segment to lower segment ratio. Again, when the upper segment to lower segment ratio is decreased, means it is called as what? Short spine dwarfism. It is called short spine dwarfism. The causes are one is part spine. One is part spine. One is part spine. Second one is mucopolysaccharidosis, MPS. Second one is mucopolysaccharidosis, MPS. And finally, when the upper segment and lower segment are proportionately decreasing, when the upper segment and lower segment are proportionately decreasing, you need to consider growth hormone deficiency. When the upper segment to lower segment ratio are proportionately decreasing, you need to upper segment to lower segment ratio are proportionately decreasing. It is a case of growth hormone deficiency. That is called proportionate short stature. So when you have upper segment to lower segment ratio equally reduced, then that is growth hormone deficiency. So these are all the things that you need to know while evaluating a case of short stature. First of all, what are all the causes for short stature? Second one is how to apply bone age chronological age with respect to short stature. Third one is how to apply your upper segment lower segment ratio to find out the etiology of short stature. Okay, done. Let us go to the seventh question. A 15-year-old boy presents to your OPD with a short stature. He had already been investigated several times for short stature. His bone age is normal. So that is the clue. Bone age is normal means bone age must be equal to chronological age. SMR is normal for age. So what does it mean? There is no delayed puberty. Father is short. There is no delayed puberty in father. What is the treatment? Testosterone, growth hormone, nutritional support. No treatment is needed. Here the clue is, what is the clue here? Here the clue is bone age equal to chronological age. The only condition where bone age equal to chronological age is familial short stature. If the father is short, mother is short, the child will be automatically short because of the genetic tendency. Is there any treatment offered to all those children? The answer is no. So the no treatment is required. This is with respect to short stature evaluation. So what are all the things we have read? How to approach a short stature. Second point is what are all the steps in evaluating the short stature. Third one is bone age chronological age, and fourth one is upper segment to lower segment ratio. Okay, right. Identify the noisy breathing. Stridor, snoring, rattling, grunting and wheeze. Okay, let me show you a sound. You identify whether it is, what sound it is shown here. What is this sound? I repeat, what is this sound? Answer. So what is this sound? So respiratory sounds are divided into three. Respiratory noises are divided into two. Either it can be heard in the inspiration or it can be heard in the expiration. Either it can be heard in the inspiration or it can be heard in the expiration. Inspiration, either it arises from the nasopharynx, nose, that is called stertor. Stertor means respiratory secretions producing inspiratory sound during breathing. One. Second one is snoring. Third one is stridor. Fourth one is rattling. Stertor is due to nasal secretions. Snoring is due to presence of adenoid in the nasopharynx. Stridor is due to laryngeal pathology, most common laryngeal pathology, and rattling is due to secretions in trachea. All are inspiratory noises. In stridor, two most common causes. In newborn, whenever a child newborn without any failure to thrive and often hearing, you could hear some inspiratory noises. That is most often a laryngomalacia in a newborn. Whereas in case of preschool children, the most common cause for stridor is ALTB, and even a foreign body. Very rarely it can be due to bacterial infections like epiglottitis. So this is inspiratory. What are all the expiratory sounds? Expiratory sounds occur at the level of bronchi, and one it is due to grunting. Both are expiratory noises. Both are respiratory noises. The first one is wheeze. The second one is grunting. Both are expiratory noises. Remember, wheeze is due to obstruction at the level of bronchus, whereas grunting is due to parenchymal disease. Parenchymal, or otherwise known as alveolar interstitial disease. Grunting is nothing but artificial peep produced by the body against the closed glottis. So this is with respect to approach of the neonatal respiratory sounds. Approach of respiratory noises. So with respect to inspiration, you have stertor, you have stridor, you have rattling, and you have snoring. Whereas with respect to expiration, either it is at the level of the bronchus, which is called as wheeze, or it can be due to alveolar pathology, which is nothing but your grunting. Both are expiratory noises. Respiratory noises. Okay, now what is this case? The following are true about this 4-year-old child with recurrent pneumonia and oily stools. I repeat, the following are true about this 4-year-old boy with recurrent pneumonia and oily stools. You need to know the causes for recurrent pneumonia and oily stools. First, you need to know the cause for recurrent pneumonia. So very simple. Define recurrent pneumonia. Can anyone tell me what is called recurrent pneumonia? Recurrent pneumonia is occurrence of two or more pneumonia in a span of 6 months. What are all the causes for recurrent pneumonia? Recurrent pneumonia can be due to aspiration, which can occur in cases of cerebral palsy or mitochondrial dysfunction. 1. Basically, beyond that, how recurrent pneumonia is divided or classified, whether it involves same lobe, whether it involves multiple lobes. So what are same lobe? Pneumonia each and every time involving the same lobe. It can be a lung malformation. or it can be an intraluminal foreign body, same lobe pneumonia. Whereas multiple lobes are involved means either it can be due to aspiration such as tracheoesophageal fistula, or it can be due to neuromuscular disorders, so that the child is prone for recurrent aspiration, or it can be due to mucociliary dysfunction. What are all the mucociliary dysfunction? One is mucus, another is ciliary. Mucus is cystic fibrosis, ciliary is primary ciliary dyskinesia, and finally you have primary immunodeficiency. So these are all the basic causes for recurrent pneumonia. And what is this case? Recurrent pneumonia with oily stools. What does it mean? Recurrent pneumonia with oily stools, that is otherwise known as pancreatic insufficiency. So now the question says you need to go for recurrent pneumonia with oily stools. Oily stools means pancreatic insufficiency. Two conditions are prone to produce this recurrent pneumonia with the pancreatic insufficiency. What are all they? Insufficiency. Two common conditions. One is cystic fibrosis. Second one is Schwann-Diamond syndrome. This is associated with bone marrow hypoplasia. Bone marrow hypoplasia and pancreatic insufficiency. So what is this case? This case is a case of recurrent pneumonia with oily stools, and when you see in the X-ray numerous pneumonia occupying the right upper lobe along with the numerous cyst-like things, nothing but cystic fibrosis. So with respect to identification of cystic fibrosis, what are all the causes for, what do you mean by cystic fibrosis? First of all, can anyone tell me? You all know that whenever someone says what is cystic fibrosis, invariably you will think in terms of delta F508 mutation. Yes, I agree. It is delta F508 mutation. But the question is, what is the pathophysiology in cystic fibrosis? Can anyone tell me what is the pathophysiology in cystic fibrosis? What is the pathophysiology in cystic fibrosis? What is the pathophysiology in cystic fibrosis? The answer is very, very simple. Cystic fibrosis is characterized by defect in chloride transport. Into the lumen. So what will happen? Sodium will not go, water will not go along with the chloride into the lumen. So that what will happen? Intraluminally, you will get thick mucus. Intraluminally, you will get thick viscid mucus. This viscid mucus will obstruct. There are so many obstructions. One is airway, second one is pancreatic duct. Airway obstruction leads to bronchiectasis. Whereas what is that? Pancreatic destruction leading to pancreatic insufficiency. These are all the common things that can occur in cystic fibrosis. Because of this viscid thick secretions, there are biofilm formation. This biofilm will harbor pseudomonas. this biofilm will harbor pseudomonas, and it is very difficult to eradicate this pseudomonas. What are all the other manifestations? Can anyone tell me what are all the anti-pseudomonal drugs? Often asked question in pediatrics, medicine, as well as in pharmacology. What are all the drugs for pseudomonas? The drugs for pseudomonas, one is ciprofloxacin, second one is aminoglycosides, third one is beta-lactam antibiotics such as piperazolin, tazobactam, carbapinums such as meropenem and imipenem, and ciproaminoglycosides, peptas, carbapenems, and then special cephalosporins such as ceftazidime and cefapirazone. What else? Did I miss anything? Whereas inhaled drugs are, one is colistin is used as inhaled drug, aztreonam can be used as an inhaled drug, and tobramycin are used as inhaled drug in case of cystic fibrosis to eradicate pseudomonas. Apart from cystic fibrosis, one more dreaded microorganism that can cause death of the child is Burkholderia. The death of the child is Burkholderia cepaceae. Apart from pseudomonas. What are all the other manifestations of cystic fibrosis? Apart from this? Other manifestation 7, 8. As I told you, it is prone for bronchitis. The child is prone for bronchitis. What else? The child is prone for meconium ileus. Obstruction, meconium ileus. Rectal prolapse. It can present as hemorrhagic disease of newborn, late onset hemorrhagic disease of newborn due to fatty malabsorption, vitamin K deficiency. What else? Bronchiectasis, rectal prolapse, hemorrhagic disease of newborn. And what else you can have? You can have recurrent pancreatitis. Pancreatic insufficiency. What else? Liver can go for cirrhosis. 14. Patient can go for nasal polyp, but cystic fibrosis is less likely to produce middle ear infection. Not that common when compared to Bruton's A gamma globulinemia or when compared to primary ciliary dyskinesia. Middle lobe infections are less common in cystic fibrosis. Apart from that, majority of males are infertile. While majority of males are infertile because complete absence of bilateral vas deferens. So what is the investigation of choice for cystic fibrosis? 1. Investigation of choice is sweat chloride test. A sweat chloride of more than 60 millimole per liter on two occasions 4 weeks apart, on 2 occasions 4 weeks apart becomes the criteria to diagnose cystic fibrosis. 1. Sweat chloride test. Second one is you can do mutational analysis. There are so many cystic fibrosis gene and it should be homozygous. And finally you can measure transnasal potential difference. Transnasal potential difference because of the differential transfer of sodium in the nose. So these are all the things to confirm your cystic fibrosis. What is IRT? IRT is nothing but immunoreactive trypsinogen. What do you mean by immunoreactive trypsinogen? See, because of the ductal obstruction by the thick mucus, the pancreas would have got damaged even in utero, as a result of which the damaged pancreas will release trypsinogen, that is called immunoreactive trypsinogen. This is a newborn screening test. Immunoreactive trypsinogen. One more test to identify pancreatic insufficiency is fecal elastase. Okay, is fecal elastase. Okay, is fecal elastase. Right, is fecal elastase. These are all the tests for cystic fibrosis. These are all the manifestations of cystic fibrosis. What is this question? So the following are true about this 4-year-old boy with a recurrent pneumonia and oily stools. So do sweat chloride test. Recurrent pneumonia and oily stools can occur in one is cystic fibrosis and then Schwann-Diamond syndrome. But most commonly in India it is cystic fibrosis. One is do sweat chloride test. Second one is fecal elastase will be low. Yes, the answer is correct because of pancreatic insufficiency. Pseudomonas colonization. The answer is yes. Pseudomonas colonization. Third one is frequent ear discharge. Frequent ear discharge is a manifestation of primary ciliary dyskinesia. Okay, is a manifestation of primary ciliary dyskinesia. Which one? Frequent ear discharge. It doesn't mean that ear discharge will not occur in cystic fibrosis, but it is not as common as in case of primary ciliary dyskinesia or immunodeficiency, such as Bruton's A gamma globulinemia. So there are so many questions that can be asked in cystic fibrosis. What are all the questions that can be asked in cystic fibrosis? What is the most common organism that is isolated? There are so many mutations. One such mutation is delta F508. What are all the anti-pseudomonas penicillins? What are all the various manifestations of cystic fibrosis? What are all the investigations for cystic fibrosis? That's it. Okay, investigations for cystic fibrosis. The next question. What is the next question? A 10-year-old boy born of 3rd-degree consanguineous marriage is brought with the complaints of recurrent episodes of lower respiratory tract infection. That means bronchiectasis, recurrent episodes of otitis media, medullary infections, which is present even now. Is X-ray showed bilateral lung inflation and peribronchial infiltrates, and CT shows bronchiectasis changes. CT paranasal sinuses revealed extensive sinusitis. What is the post probable diagnosis? So what is the spotter shown here? The answer is very well written here. What is the spotter shown here? Can anyone catch the diagnosis? What is the spotter shown here? So the spotter shown here is very good. Situs inversus totalis. Whenever you see a case of bronchiectasis with situs inversus totalis, the diagnosis is usually Cartagena syndrome. Cartagena syndrome is a component of primary ciliary dyskinesia. So when you need to consider primary ciliary dyskinesia, when you consider primary ciliary dyskinesia, when you consider primary ciliary dyskinesia, 1. Primary ciliary dyskinesia is due to defect in the cilia involving the respiratory tract, both upper and lower respiratory tract. So what are all the manifestation? One is frequent ear discharge. One is frequent bilateral ear discharge with or without deafness. Second one is chronic rhinorrhea or otherwise due to sinusitis. Sinusitis. Third one is bronchiectasis. Third one is bronchiectasis. Fourth one is situs inversus totalis. Fourth one is situs inversus totalis. Fifth one is what else you can have. So these are all the manifestations of primary ciliary dyskinesia. What is the screening test? What is the screening test? The screening test is very simple. Nasal nitric oxide. The screening test is nasal nitric oxide levels. Nasal nitric oxide levels of less than 70 parts per million is the screening test of choice. So what are confirmatory test? What are confirmatory test? The confirmatory test are, one is high speed video microscopy. One is high speed video microscopy. One high speed video microscopy. Second one is, in that high speed video microscopy, your ciliary beat frequency will be calculated. Whether the cilia is beating or not, you will see. In a normal biopsy, cilia will be seen, but in case of primary ciliary dyskinesia, ciliary beat will not be there. Second one is ciliary beat frequency. Second one is mutational analysis. Second one is mutational analysis. It will detect your dyneema mutation, so many things, etc. So these are all the confirmatory tests for primary ciliary dyskinesia. Third one, apart from that, what else? So one is high speed video microscopy. Second one is mutational analysis. Third one is, can anyone tell me? Okay, electron microscopy. Looking into the electron microscopy of ciliary biopsy. Electron microscopy of ciliary biopsy. These are all the confirmatory tests. So the screening test is only one, nasal nitric oxide, whereas the confirmatory tests are high speed video microscopy, mutational analysis and electron microscopy with ciliary biopsy. This is about primary ciliary dyskinesia. So what is this? Here you have situs inversus totalis with the bronchiectasis, with rhinorrhea, deafness and then atoria, more in favor of your primary ciliary dyskinesia. More in favor of your primary ciliary dyskinesia. That's it. Then next question 11. The following are true about duct dependent lesion except. The following are true about duct. Duct means patent ductus arteriosus. The following are duct dependent lesions except. So what are duct dependent lesion? Let us see. What are duct dependent lesion? Let us see. So your patent ductus arteriosus, at times useful for systemic circulation. At times useful for systemic circulation. At times useful for pulmonary circulation. At times it is useful for, one is systemic circulation, at times it is useful for pulmonary circulation, at times it is useful for mixing of lesions. So how does your duct dependent lesions will manifest with? Your duct dependent lesions can manifest based on whether it is a duct dependent systemic circulation or a duct dependent pulmonary circulation. Your duct dependent systemic circulation usually presents with shock. A child by about 3rd or 4th day, a newborn by about 3rd or 4th day is brought with the shock. You need to think in terms of duct dependent systemic circulation, because it can be a manifestation of critical aortic stenosis, or it can be a manifestation of coarctation of aorta. In those instances, in the first 3 days of life, the duct acts as a bypass, so that the blood from the heart bypasses the obstruction through the ductus arteriosus into the lower part of the body. So by about 3rd or 4th day, when the ductus closes, it will manifest in the form of shock. Whereas duct dependent pulmonary circulation usually manifests in the form of cyanosis. For example, tricuspid atresia, pulmonary atresia, etc. And finally, duct depends, or the duct is dependent mainly for mixing of lesion that occurs in a case of transposition of great arteries. In that, by about 3rd or 4th day, when the ductus closes, there is no place for the oxygenated blood or unoxygenated blood to mix, as a result of which your TGA will manifest as cyanosis on 3rd or 4th day when the ductus closes without any murmur. Okay, so now tell me, what are all the lesions that we have seen so far? So one is ductus is PDA. So one is duct dependent pulmonary circulation, which usually manifests as cyanosis by about 3rd or 4th day. What are all the diseases? Tricuspid atresia, pulmonary atresia. 2 diseases, tricuspid atresia, pulmonary atresia, severe forms of tetralogy of Fallot. One. Second one, what about systemic circulation? Usually these conditions will present as shock on the 3rd or 4th day. So what are all the causes? Either it can be critical aortic stenosis, or it can be a coarctation of aorta. This is duct dependent systemic circulation condition. Third one is duct mainly for mixing of blood. What are all the condition? Transposition of great arteries. Because in transposition of great arteries, your pulmonary artery arises from right ventricle, and your aorta arises from your pulmonary artery arises from left ventricle, and aorta arises from right ventricle, as a result of which it will follow a parallel circulation rather than serial circulation, leading to intense cyanosis after birth or after the ductus closes. So these are all the duct dependent conditions. So what are all the duct dependent conditions? Tricuspid atresia, pulmonary atresia, tetralogy of Fallot are duct dependent pulmonary circulation. Critical aortic stenosis, coarctation of aorta are duct dependent systemic circulation. And a duct which is dependent for mixing of lesion is transposition of great arteries. And finally, duct independent lesion. What are duct independent? Duct independent lesions. Duct independent, because whether it is duct closes or not, that is not a problem. That is your total anomalous pulmonary venous connection. One is total anomalous pulmonary venous connection, in which all 4 pulmonary veins will arise from the right atrium or superior vena cava. All 4 pulmonary veins will end up either in the right atrium or superior vena cava or in the inferior vena cava. In that, whether duct is present or not, that is not an issue. Second one is truncus arteriosus. What is truncus arteriosus? See, your pulmonary artery should arise from the right ventricle and aorta arise from the left ventricle. But in truncus arteriosus, a single common trunk will arise from the heart and then it will divide it into aorta and ventricle. This total anomalous pulmonary venous connection and the truncus arteriosus do not depend on ductus. So, what is the answer? Again, this is an often asked question. So, the following are duct dependent lesions. Tetralogy of Fallot, yes. Coarctation of aorta, yes. What is that? Hypoplastic left heart syndrome. Again, hypoplastic left heart syndrome is also a duct dependent systemic circulation conditions. So, what are all the conditions which doesn't require ductus? One is total anomalous pulmonary venous connection. Second one is truncus arteriosus. Except these two conditions, all are duct dependent lesion. Again, an often asked question, which one is duct independent? They will ask you. Duct independent, they will ask you. Right. Again, a simple approach to congenital heart disease. How to approach a congenital heart disease? So let me write in a simple way. So please follow me. Congenital heart disease. So how to classify congenital heart disease? A simple classification. A congenital heart disease can be a cyanotic or acyanotic congenital heart disease. Acyanotic congenital heart disease. Okay, this acyanotic congenital heart disease, which will be again divided into two. This acyanotic congenital heart disease will be divided into two. One is left to right shunt. Another is obstructive lesions. What are left to right shunt lesions? At the level of atrium AST, at the level of ventricle VST, at the level of large arteries such as PDA. Whereas obstructive lesions are one is critical aortic stenosis. Second one is coarctation of aorta. Critical aortic stenosis and coarctation of aorta. So what is the manifestation of these diseases? See this, which one? Left to right shunt. How does it manifest? Left to right shunt. Blood is moving from the left side of the heart to right side of the heart. What are all the manifestations? If it is small, it can be asymptomatic. Because of the left to right shunt, your pulmonary congestion will be there, leading to recurrent pneumonia. If it is large enough, it can cause failure, congestive cardiac failure. And if it is untreated for a long period of time, you all know that blood is shifted from the left side of the heart to right side. So what will happen? Your right side of the heart means lung. The lung will be exposed to more and more blood. When the lung is exposed to more and more blood, the intima of the pulmonary vasculature will be thickened, leading to what? Pulmonary hypertension. When pulmonary hypertension comes, what will happen? The left to right shunt become right to left, leading to cyanosis. This is called as Eisenmenger syndrome. So the manifestation of ASD, VSD, PDA are either it can be asymptomatic, or it can produce a recurrent pneumonia, or it can be produce congestive cardiac failure, cyanosis, or Eisenmenger cyanosis, which is nothing but Eisenmenger syndrome. Second, what is the manifestation of critical aortic stenosis and coarctation of aorta? Very, very simple. As I told you, shock immediately after birth on the 3rd or 4th day of life. Or in case of critical aortic stenosis, it can produce angina. In case of coarctation of aorta, it can produce claudication of lower limbs. These are all the manifestation of acyanotic congenital heart disease. When you come to cyanotic congenital heart disease, okay, I write here very now you come to cyanotic congenital heart disease. Cyanotic congenital heart disease. Nothing but blue baby. The child becomes suddenly blue by about 3rd or 4th day after birth when the ductus closes. Cyanotic congenital heart disease. In cyanotic congenital heart disease, basically it is divided into two. One is whether it is associated with decreased pulmonary blood flow. One is decreased pulmonary blood flow. In decreased pulmonary blood flow, what are all the things you need to know in decreased pulmonary blood flow? The presentation is cyanosis. The presentation is cyanosis. Presentation is cyanosis. Decreased pulmonary blood flow means you need to, in all these cases, heart size is normal. You need to look into the heart size. The manifestation is cyanosis. You need to look into the heart size. Heart size. Then you can have a large heart. You can have a large heart. Large heart, largest heart, cyanotic congenital heart disease, largest heart is Epstein's anomaly. Largest heart is Epstein's anomaly. Whereas small heart, whenever you have normal heart size, whenever you have normal heart size, then it is divided into two. One is whether it is associated with the left axis deviation or it is associated with the right axis deviation. Left axis deviation means it is a case of tricuspid atresia. It is a case of tricuspid atresia. Whereas right axis deviation means it is a case of tetralogy of Fallot. It is a case of tetralogy of Fallot. It is a case of tetralogy of Fallot. Okay, this is very important. By just following this simple flow chart, you can definitely crack through a question when it comes from the heart disease. Okay, then second one is increased pulmonary blood flow. Second one is increased pulmonary blood flow. Here what happens, you will have both cyanosis as well as you will have CCF, combination of cyanosis with the CCF. So what are all the manifestations here? When you have CCF, congestive cardiac failure, plus early onset cyanosis, plus you have one is CCF, second one is early onset cyanosis, then you have features of AST. What is this called as? This is nothing but total anomalous pulmonary venous connection. Total anomalous, when you have, remember, when you have an AST, you don't have CCF or cyanosis in the first 6 weeks of life because of the increased pulmonary pressures. When congestive cardiac failure occurs in a case of child with features of AST, or the child in AST usually do not go for cyanosis. If it goes for cyanosis, if it goes for CCS, a case of ASD, child with ASD feature, think in terms of total anomalous pulmonary venous pressure. This total anomalous pulmonary venous condition. So what is this? So here 4 pulmonary veins draining either into superior vena cava or into heart or into inferior vena cava. Superior vena cava, when all those veins are draining into superior vena cava, it is called supracardiac total anomalous pulmonary venous connection. When all those 4 pulmonary veins, instead of draining into the left atrium, if it drains into right atrium or a common sinus, it is called cardiac type of TAPVC. Or if it drains into the inferior vena cava, it is called infracardiac TAPVSC. Infracardiac total anomalous pulmonary venous connection. Okay, remember Among this supracardiac and cardiac, this infracardiac TAPSC usually presents in the newborn period. Usually presents in the newborn period. Newborn period, or in the second or third day itself, with a triad of cyanosis, normal heart size, cyanosis, normal heart size, and ground glass lung field, GGO, ground glass lung fields. The triad of cyanosis, normal heart size, or ground glass lung fields in the third or fourth day of life is called as infracardiac TAPSC, and it mimics dash. Which one? Hyaline membrane disease. Remember, this is an absolute surgical emergency. This is an absolute surgical emergency. Absolute surgical emergency. Okay. Emergency. The second condition is, one is total anomalous pulmonary venous connection. The second condition is TGA. What is TGA? Pulmonary artery arises instead of arising from the right ventricle, it arises from the left ventricle. And your aorta, instead of arising from the left ventricle, it will arise from the right ventricle, so that a normal serial circulation, usually heart is in the serial circulation, will be converted into parallel circulation. What is the presentation of a transposition of great arteries? The presentation of transposition of great arteries is whenever you have a term baby, large baby with cyanosis on the third day or fourth day, I repeat, without any murmur, is called as TGA. So what is the treatment for TGA? Can anyone tell me what is the treatment for TGA? The treatment of TGA is step 1. What is step 1? The child becomes cyanosis because the ductus is getting closed. So that open the ductus. How do you open the ductus? Prostaglandin E1 and prostaglandin E1 analogs. Prostaglandin E1 analogs. Open it. Step 2. But this is not enough for the admixture of oxygenated and deoxygenated blood. So you need to go for balloon. What is that? You need to go for balloon atrial septostomy. Balloon atrial septostomy. Step 2. What is step 3? Step 3 is corrective surgery. What do you mean by corrective surgery? You need to take the pulmonary artery, you need to take the aorta. So pulmonary artery, you need to take it from the aorta and keep it over the you need to take it from the left ventricle and keep it over the right ventricle, and aorta you need to take it from the right ventricle and keep it over left ventricle. So okay, this is what is this called? This is called arterial switch surgery. This is called arterial switch surgery. This is called arterial switch surgery, otherwise known as Japanese. Otherwise known as Japanese arterial switch surgery. Balloon atrial septostomy is called as Rash-kind balloon atrial septostomy. Rash-kind. And finally, when the child comes very late, you can do only palliative surgery. Palliative surgery. Palliative surgery is called mustard and senning. This is atrial switch surgery. So what happens here? Here your right atrium will be attached to left ventricle and the left atrium will be attached to right ventricle. This is called palliative surgery, or otherwise known as mustard and senning. This is otherwise called as mustard and Senning surgery. This is all about your TGA. So we had a bird's eye view of almost acyanotic and cyanotic congenital heart disease. And to conclude our session, we need to concentrate on most important T. What is the most important T? Tetralogy of Fallot. Most important T is tetralogy of Fallot. So what are all the 4 components of tetralogy of Fallot? As you all know. So now a small revision on tetralogy of Fallot. So what are all the 4 components? Component 1, you have pulmonary stenosis. Second one, you have right ventricular. So pulmonary stenosis is a form of right ventricular obstruction. So it leads to right ventricular hypertrophy. Second component. Third component, you have a large VST. And fourth component, aorta will be overriding into the VST. These are all the components. 1. So what is the manifestation? The manifestation is cyanosis on the 3rd or 4th day, or else you can have a cyanotic spell. What is this cyanotic spell? Let me tell you a case scenario. A cyanotic spell is a baby between 2 months or anything, roughly 2 months to 6 months, will be brought with sudden respiratory distress. So that a child will have a tachycardia, a child will have a tachypnea. And child will be having a tachypnea. So what will happen? Previously the child will be having a saturation of maybe around 65 to 70. Now drop in saturation from the previously compared value. So let us say 25% oxygen saturation. Why? Because the stenosis would have gone further. The pulmonary stenosis would have gone further, so that your ejection systolic murmur is not heard. Not heard because of the increase in the pulmonary valvular stenosis. What is the treatment of choice? 1. You need to put the first oxygen. Any child who is hypoxic, you need to give oxygen. Second one is knee chest position. By doing knee chest position, you can, by doing a knee chest position, what happens? You are increasing the systemic BP, so that the left to right shunt cannot happen. Third one is sedate the child with morphine. These are all the common things to treat a case of cyanotic spell. Whenever a child has gone for cyanotic spell, after treatment of this spell, invariably you need to go for 2 things. One is put the baby on propranolol, so that your cardiac demand is decreased. Second one is plan the baby for corrective surgery. If corrective surgery is not possible because of the severe cyanosis, you can go for palliative surgery. Not palliative, an interim surgery. What is this interim surgery? Interim surgery is your Blalock tossing shunt. What is this Blalock tossing shunt? Very, very simple. You will connect the subclavian artery. To the pulmonary artery, so that there is a stenosis here, pulmonary valvular stenosis here. Here the pulmonary artery is normal. You will connect the subclavian artery to the pulmonary artery, so that the blood from the subclavian artery will go to the pulmonary artery and it will reach the lung, gets oxygenated, again come back to the lungs. lungs. This is all about tetralogy of Fallot. So what is the question here? Among the following, which is true regarding tetralogy of Fallot? Cyanosis is never present in newborn period. Remember, in more usually cyanosis presents by about second or third month. But when the pulmonary valvular stenosis is so much, it can present in the neonatal period itself. So the answer is wrong. Nietzsche's position helps in abolishing the cyanotic spell. The answer is yes. Why? Why? Because it increases the systemic hypertension so that the left to right shunt will not occur. Yes. The answer is right. Murmur due to VST may temporarily disappear during cyanotic spell. Usually murmur of VST is not heard, it is immersed in the murmur of pulmonary stenosis, that is of the ejection systolic murmur. So it is not the murmur of VST that undergoes temporary disappear, it is the murmur of pulmonary stenosis that undergoes temporarily disappearance. So the answer is wrong. Finally, in cardiac catheterization, pulmonary arterial pressure is grossly elevated than the right ventricular pressure. The answer is very, very wrong. Your right ventricle pressure is more compared to the pressure in the pulmonary artery because there is an obstruction at the level of the pulmonary artery. So your pulmonary artery pressure is less compared to the pressure of the right ventricle. This is also wrong. So the answer is B. So the answer is B. Okay, these are all the things we have discussed. Finally, the last question. A 4-year-old brought with non-healing seborrhea of the scalp for the past 3 months along with the tachypnea. So something is involving your head, something is involving your lung and something is involving your liver leading to hepatomegaly. The following are true except it can present with the diabetes insipidus, opsoclonus myoclonus can be associated with it, acquired hemophilia, bone marrow will show large atypical cells. So what is the correct answer? Look at this, look at this, look at this lesion. This lesion is so typical of LCH, so typical of Langerhans cell histiocytosis. Okay, this cell will be positive for CD1A and the histopathology will show grooved nucleus and the histopathology will show grooved nucleus, grooved nuclei will show grooved. What are all the manifestation of Langerhans cell histiocytosis? There are 3 manifestations. One is Hans Schuller-Christian triad, Schuller-Christian triad, which is associated with 1. Bilateral exophthalmos. Second one is osteolytic skull lesions. Bilateral exophthalmos, osteolytic skull lesions. Okay. Third one is diabetes insipidus by involving your posterior hypothalamus. Second, it can occur as Litterer sivi disease, which is nothing but a disseminated disease involving your liver, involving your lung, involving your skin and many organs. Finally, isolated vertebral lesions, otherwise known as eosinophilic granuloma. You might have heard about pulmonary histiocytosis in case of smokers, which is reversible in adults, but this kind of pulmonary smoker induced histiocytosis is least likely to occur in a child. Either it can be a manifestation of Hans-Keller-Christian triad, or it can be a manifestation of Letterer-Sevy disease, or it can be a isolated eosinophilic granuloma. Remember, a non-healing seborrhea in pediatric age group, unless otherwise proved, Langerhans histiocytosis. It is usually the marker is CD1A positive. Ranjit would have taught you about the presence of grooved nucleus in those Langerhans histiocytosis. So this is a case of non-healing seborrhea presence with diabetes mellitus, insipidus. The answer is this. Why? Because it involves the hypothalamus. Other causes. What about this? Opsoclonus myoclonus. Opsoclonus myoclonus is a manifestation of neuroblastoma. Acquired hemophilia. Antibodies to factor 8. Antibodies to factor 8 or 7 is a manifestation of Wilms tumor. What is this? Bone marrow will show large atypical cells with vacuoles. This is nothing but ALL-L3 type. So, not the answer, not the answer, not the answer. The answer is, this is a case of LCH presenting with diabetes insipidus. So, with this, we are finishing for our topic today. We will meet again with some important image-based, video-based session exclusively in coming Monday. With this, I am signing off. Thank you. Bye-bye. We will meet soon on Monday. Thank you.